Thank you for that kind introduction. It's really a privilege and an incredible honor to be here. It's always a little breathtaking. You wonder, like, if you've just gotten to be so old that finally you come down on the list. But I'm kind of like the little sister to those big guys. And so I'll talk a little bit about that because today is really about residents and fellows and how you figure out like what you're going to do, especially when you're surrounded by so many amazing people, which you guys clearly are here as well. So, I mean, you never see this slide at Stanford, right? So here you go. So our plan for today, we'll talk a little bit about connections and influences. I'll do an overview of the Richard D. Wood Center for Fetal Diagnosis and Treatment. We'll hone in specifically on congenital diaphragmatic hernia and the work that we've done recently, and then you'll hear some stories along the way. So has anybody ever heard of this guy? So Everett Dean. So I grew up in Indiana, a small town called Salem. It's in Washington County. And Everett Dean was also from Washington County, Indiana, and he loved Indiana. He went to IU. He was a 3-sport athlete at IU and my high school, Salem High School. And then he went on to be, he went to Carleton for a couple of years, and then he came back and was the head coach, basketball coach of Indiana, but also the baseball coach. And in 1938, he got pegged by Stanford to come and be the basketball coach here. He won 3 Big Tens at IU back when they were 10 teams. And then he came to Stanford and they won the NCAA, their first NCAA in basketball in 1942. And then remarkably, he stayed on in basketball, very successful. In 1950, he became the baseball coach at Stanford. And in 1953, they won the College World Series. So he's the only coach that won both the NCAA basketball and the College World Series. And he's in both Hall of Fame. And he's a Stanford through and through. And then after he finished his time in Stanford in the 50s, he came back to Salem because he loved Washington County, Indiana, and he opened the John Hay Museum, and he did a lot of work in our community, and he was just a nice. And then how about this guy? Has anybody heard of this one? This is a little sordid past, sort of a little mixed legacy. David Starr Jordan was the president of Indiana University, and he was the first president of Stanford. And this is an awesome book. It's called Why Fish Don't Exist by Lulu Miller. I feel like I live with Lulu Miller because my daughter listens to her podcast all the time. But this is Mrs. Stanford over on the left, and it's highly suspected that he had something to do with her death by poisoning. Little intrigue. So because this is about residents and about journeys, I just thought, you heard I came from Indiana, and it was a big, crazy place. And we were really good at basketball back then, and Bob Knight was there. And then I went to Duke again, crazy about basketball, won the first NCAA. I think every year I was in med school, we went to the Final Four. And when you were a medical student, you could just renew a packet. You didn't have to camp out. So you just renewed your packet, and you went every year. And it was really quite fun. But, this is where you get inspired and you meet people, and you never know which lecture you're going to go to that's going to be the one that changes your life and changes your choices. And so I went from Duke, I went to the Brigham, and it was at the Brigham, you're tired, you're a resident, like there's one more lecture. Oh, can I stand it? Dr. Adzik talked about fetal wound healing, and that was the lecture that I went to that changed my life, right? I did work with Dr. Donahoe, who, to say that she is incredible is like an understatement to this day. I mean, I think she's in her 80s. She will schedule a meeting and want to talk about something to do with CDH and developmental biology at 10 a.m. on a Saturday. Still, I'll like come up on my phone. Oh, so just incredible work ethic. And then again, Dr. Adzik has been frontier breaking in all things fetal surgery, and really in just building a team of excellence. When I was at the Brigham, Dr. Moore, the senior, wrote A Miracle and a Privilege. I asked him to sign my book, and then I wrote him a thank you note for signing my book, and then he wrote me a thank you note for my thank you note. So it's just important to like realize your history and the people that are impacting you. So that being said, then I went to CHOP, which is America's oldest children's hospital, 1855. It's actually the code on every keypad to every place you need to go in CHOP, in case you need to know. But it started off in a little house on Bright Street, then it went to Brainbridge, and then the far right is what it looked like, I think, when Carl and I were first in Philadelphia. It was brown and ugly. It was also the most expensive building in Pennsylvania when it opened in 1974. And then this is what it looks like today. This is the inpatient building on the left. There's a big tower going up that's rendered to the left side. And then this on the right is the outpatient building. There were 3 research towers, and they're building all the time. So my mentor also included Dr. Louise Schnoffer, who was at CHOP. She was Dr. Koop's very first fellow, and she spent 40 years at CHOP. She endowed our fellowship, and so this is a picture of some icons in the center there. So Mike Nance is now our division chief, and of course Dr. Adzik, looking very young and dapper, is our surgeon in chief, and then Dr. O'Neill is just behind. So lots of connections, right? And then it really is about the people, right? I showed you a bunch of buildings, but who cares? It's the people, and these are you're in the trenches together, and you remember them forever. So these are a group of our fellows down at a change dinner on the left, and then this is one night. It's 10 p.m. An unexpected SCT is bleeding, gets born, and all of the fellows stay. Like there's 4 fellows, and they're all women. It's pretty amazing. So if there's one theme for today, it is that working together really gets it done, right? It gets it across the finish line, and is appreciating all the things that the other specialties, the other disciplines have to offer. So the main problem with that I'm going to talk about is birth defects. They're common, and they cost a ton of money, and we always want more money, and that's getting harder and harder to do, and it still is the leading cause of infant mortality. The Center for Fetal Diagnosis and Treatment opened in 1995, and it was Dr. Scott Adzik, who Carl mentioned, and Lori Howell. And this is truly a partnership, right? This is a nurse and a physician, and they partnered and they built a program like no other. This is just a timeline of some of the achievements, which is impossible to read. And then the CVFTT patient experience, which is really like core. It's kind of like the North Star of what they try to do, or we try to do. And so it starts with the first phone call. A patient gets a coordinator. They sort of shepherd them through the process. Team counseling is a differentiator. We really try hard to counsel patients together, to not have it be, you're going to go over and talk to the MFM, and you're going to come over and talk to the surgeon, because you invariably have conflicting information if you do it that way. And so we really do work to maintain that model. It's hard. It's really hard to do. Like, we always want to be in the OR, right? We want to hide, but it's important. And then educating the families so that they can make decisions. And then there's a few tenets related to the CFTT or the fetal program, in that it is often a home away from home. These families often have to move to Philadelphia in order to be cared for. I'm sure it happens in Stanford too. It's why Ronald McDonald House has sprung up all over the world. There's a new movie coming out, by the way, on the 28th about Audrey Evans and the Ronald McDonald House and her work in cancer. So this part is a wraparound psychosocial services, and it just grew and grew and grew. It started off with one coordinator. Now there's 5 or 6 coordinators. There's multiple social workers. There's a PhD psychologist. And so another tenet, which is super important, is, you have to track what you do, and every single thing you do. And it has to be the patients that do well, but it also has to be the patients that don't do well, because how else are we going to change what we do in the future? And so this is just a smattering. The kid, believe it or not, down bottom right, is in the service, and he did have a CDH with a patch. So to do this, we have to have ways to collect our data. We have to have ways to analyze it. We have to have ways to follow it. This is just an example of some of the volumes of data that we have collected, over 7 million data points for CDH alone, with the maternal dyad together. And so there was a software solution that was actually invented or co-invented with a surgical resident and one of our business analysts. And so this is what we use. It's called CODA. And then the another pillar of the center is this application of new discoveries. And so, all of the focus is on, real time taking care of the patients the best we can, but it's also on pushing for new discoveries. And so there's several projects that are ongoing and have lots of incredible people working on them, including my partners, Dr. Emily Partridge, Dr. Bill Pronto, and Alan Flake, who's going to change the world with his artificial womb. So you guys heard about that a few years ago, right? And then just to further go along sort of surgical tenets or tenets of the program, this is an old essay that was published in 1990, Dr. Adzik, and it's about a surgeon's notebook. It's about keeping track of what you do and writing it down and learning from every case. And it's actually worth reading, and it's actually worth doing. You can do it in all kinds of fancy ways now too, right? I think the residents are using Evernote, or it's on digital, and they pass it around, and there's going to be some incredible book published someday about this. And really empowering every member of the team. You knew I was going to do this, right? Does everybody know who won the Super Bowl? We have razzle dazzle stars on our team, but we've also got the O-line. That's me. We've also got all the people that make the whole thing happen. And so it's a very orchestrated team, and all the members are super important. So just to rattle through what we do in the CFDT. So we are now up to about 2,400 fetal interventions, which I think Dr. Adzik quotes it as it's a quarter of all fetal surgeries that have been done in the world. I'm going to focus on congenital diaphragmatic hernia, for which we've evaluated more than 2,000. And this is just the overview. This is the journey. And so you could really plug in any diagnosis here. So it's this prenatal piece. It's the get born a special way, we call it the golden hour of delivery. I used to always think it was just trauma, but I guess it's delivery too. And then the neonatal surgery team, which is a co-managed team with surgery, with subspecialties, and with neonatology. And then finally, the long-term follow-up. So why CDH? It's still responsible for the most in-hospital deaths of any congenital diagnosis. And it also costs a lot. If you go on ECMO, the price is 2.5 times. So just to start off with our guidepost for the center, it really is all about the diagnosis. And so we now think of CDH as really a 3-part problem, right? So something happens at 11 weeks. The diaphragm doesn't close. The stuff that's in the belly comes up into the chest, and that has lasting impact on the number of times the airways divide, the branching of the airway, the number of alveoli we get. And so it's really a parenchymal problem, it's a vascular problem, but it's also a cardiac problem because they're intertwined. And so we now really think of it as a trifecta. And then there are prenatal predictors to try to predict what's going to happen. And this is what we do in the fetal evaluation. And so the first sort of line is there a syndromic or genetic difference? Next, is there cardiac? And then finally, is there, what are the lung sizes? And this, unfortunately, is sometimes what we talk about first. And so when we think about the CDH clinical classification genetically, isolated is 60 to 80%, but syndromic is 20 to 40%. And I more and more think like everybody's got something, right? They run these microarrays and these whole exome sequencing, and then now the whole genome, and we always come up with things, and it might be 3 years, it might be 5 years, it might be 7 years later, and we're like, oh, that actually meant something. So we're learning all the time. We actually, in all cases, are now doing whole genome sequencing. It sometimes you have to like game it a little bit and do it after they're born because it's very hard to get it reimbursed prior to that. And then this idea of CDH and ECMO, CDH and congenital heart disease. When I was a fellow, it was just a no-go. I mean, we got that first echo prior to going on ECMO because if they had a congenital heart disease, we weren't going to go on ECMO. We thought it was a completely fatal enterprise. Since then, there have been a lot of work and we've gotten more and more aggressive about things. So this is a report from the ELSO registry that shows that overall 47% survival. Now, these are all kids that people went for, right? They went on ECMO. So within that group, 47% survival. There has been a recent systematic review, which again shows that it might be worth a shot. It really matters if it's critical congenital heart disease versus non-critical. So the survival for non-critical was greater than 60%, but for critical was 32%. And that was just defined as single ventricle ductal dependent. Most kids got CDH repaired, but not all, 72%, and about a third of them went on ECMO. So then finally in this prenatal piece, it would be great to be able to tell how big the arteries were. We have a hard time doing it. There have been folks that have been making progress with that. But for the last 30 years, we've been using this number called LHR. So the LHR is the area of the contralateral lung, so the right lung and the left CDH, at the level of the four-chamber heart to account for mediastinal shift, and then dividing that by the head circumference. So it's like one plane, one shot. It always really bothered me that then we say so much about it. And then we know that if we use observed over expected, that it's much more accurate in terms of changing over time. So severe has been defined internationally as less than 25%. That's actually expanding to probably go all the way up to 30%. And then the MRI, which has traditionally been used mostly to confirm liver position, but also to do total lung volumes and now actually liver percent as well. So these are complementary. There's not one that's better than the other. But when we've recently looked at our own population, it does look like the cutoffs for severe are closer to 30% for the left and around 45% for the ODE LHR on the right. The MRI is similar findings. So that begs the question, can we intervene now that we know this much? We know all these things about these babies. Can we do something that changes the trajectory? And that's always been the goal of fetal surgery and fetal interventions, to notice something, to track its natural history, to figure out what's going on, and then to potentially offer an alternative path. And so this was something that was attacked really early on, like back in the 80s. There's a series of papers that are called Lessons Learned, and they're pretty dismal. And so, in the beginning, it was, let's try to fix the hernia. As soon as the umbilical vessels were kinked, the babies died. And then we know that liver down CDHs don't need to have a fetal repair. So that was abandoned, and then a physiologic approach was taken up, which is occluding the airway to cause increased stretch to cause proliferation. The folklore goes that Jay Wilson was at the Countway Library Xeroxing a paper, and on the back side of the paper he saw this paper about congenital high airway obstruction. He thought, why don't we use that for CDH? Why don't we block the airway? And so that's how this was born. So in the 90s, Jan Deprest in Leuven developed a completely minimally invasive technique for occluding the airway, which is a single trocar. It's a fetal bronchoscopy. It's then deploying a tiny balloon, which is the size of a piece of risotto before it's blown up, just beneath the vocal cords, and then knocking that off, and then coming back in the 34th week and removing it. It's very important it gets removed, because otherwise you don't have surfactant production in type 2 cells. So this was a tour de force. It's called the TOTAL trial. It was published in the New England Journal in 2021. It's a classic. And what this showed was multi-center, international, started, his first pitch to the NAFNet was in 2007, and this is published in 2021, just to give you an idea of how long it takes to get something like this done. It was stopped early for efficacy in the severe arm. And what it showed was survival to discharge improved from only 15% to, only 11% to 40%. So it's hard to compare with the United States, because our baseline survival is not 15, it's not 11, it's definitely not 40. So, so this has been the argument of us just sort of adopting it worldwide, because we have different place we're starting. And then the downside is the babies were born premature 75% of the time, or less than 37 weeks, and the moms had membrane issues. So the North American Fetal Therapy Group, which is NAFNet, has several centers that are doing balloons. It's all the little purple dots. And, they've really, in the United States, it started just down the street. Craig Albanese was involved with many of those cases way back. And so, this has also been a tour de force to try to get the permission from the FDA to use the balloon. And so, nobody's better about getting devices across the line than Stanford. So we could have used your help. It took me 7 years and multiple meetings. And so this is just a timeline of when we see the patients, and then when we place the balloon. So ideally, the balloon goes in between 27.0 and 29.6, so between 27 and 30 weeks, and then it comes out in the 34th week. We've made a very big effort to see the patients multiple times to confirm that they really are a candidate, and also to confirm that they really know what they're getting into. And so this just shows all the little orange dots are, we just seeing them over and over again, counseling. The blue bands are where they're occluded. And then the green triangles are good. That's when we delivered and the balloon was already out. So it was planned. And that was about 60% of the time. But 40% of the time, the red triangles, it was an emergency. So they came in, they were in labor, their water had broke, and we had to scramble to get the balloon out urgently. So this is like the dark side, right? The balloon could be in place and they could be born unexpectedly. This just shows some details of the procedure. The median time for the trocar to remain in utero is 22 minutes. Less is better because you have less membrane problems. And then the way the balloon gets removed is important. So we think we're going to be better about this ultrasound needle puncture. It sounds like it would be awesome, but it's very, very hard to do. And then we've done most often by fetoscopy, so a repeat procedure, and then bronchoscopy at delivery emergently in 40%. And so that's really why you have to have this incredible infrastructure of people ready to attack an emergency. And then maternal outcomes are always important. It's two patients. The separation rate was 50% versus only 3% when they didn't have feto. A premature rupture of membranes was 75%, which correlates well with the total trial, but only 11% in the standard arm. And then the maternal median cumulative length of stay. So the number of times moms came back in because we were worried about them or because there was a membrane problem. They're in the hospital up to 2 weeks versus only 3 days if you don't have the balloon. And those are all like repeated admissions. And then all of our fetal babies actually delivered by C-section. This is something we need to work on versus 60% by C-section in the by vaginal delivery in the arm that, in the group that didn't get it. And then it's not just the balloon, right? We always think of it as if you get the balloon out, then everything's going to be awesome. But once you take the balloon out, there's all these thick secretions that have built up. It's almost like a cast. So we have to get those out, and then we have to get the lungs recruited. And so we've done some sort of non-traditional things to get the lungs open, including the VDR in a newborn. It goes that this multidisciplinary team, we've got these coaching, we have emergency simulations every single week once a balloon goes in. It's just a tour de force. And then when we look at our neonatal outcomes, the good news, the bad news is that they're younger, 35 weeks versus 39 weeks. But the good news is that the ECMO rate was decreased by half, and no patients were discharged after feto on pulmonary hypertension meds versus 30% in the severe group that did not have the balloon. And despite being early, their neurodevelopmental outcomes were similar. And so the blue bars represent the feto patients and the purple bars represent those who had standard of care. So we're moving on to like the delivery piece. So the Garbo Special Delivery Unit, or what we call SDU, opened in 2008. I mean, up until the day before, it was like there were people and naysayers saying, oh, it's not going to happen. This was a really difficult thing to happen. It was something that was planned for from the beginning of the fetal center opening, and it still took 13 years. And so these have now sprung up all over the country and all over the world, which is always, imitation is the sincerest form of flattery, right? But we really do know that it's made a difference in the care of our patients. This is just the timeline of some of the changes. We try to be a learning health system, right? So we try to learn from every single patient and feed that back into a process. And so the SDU opened in 2008. We decreased our initial FiO2 down to 50% in 2014. We used to do 100% on everybody, and they'd stay on 100% for days. And then we'd end up with complications related to that. We started doing video laryngoscopy in 2014. We had our first feto patient in 2017. 2019, for severe CDHs, we now use the high frequency from the get-go. Which despite what the VC trial said, our settings are completely different, and we think it really makes a difference in terms of having a higher pH and a lower PCO2, even if leading into ECMO. 2019, we started having weekly CDH management meetings where we talk about every single baby with CDH in our hospital with the whole multidisciplinary group. We started video recording all our deliveries in 2021. And I find this fascinating. You have the human factors expert. They tell you, oh, why are you standing there? And we end up changing the room around. And it actually really makes a huge difference. And it's fun. 2021, we reduced our use of empiric nitric by using the echocardiogram. And so if a baby has LV dysfunction, they're not going to get nitric. And then we started using the muscle flap instead of the patch. And so I have not done a Gore-Tex patch since 2020. And then 2022, we started having actually weekly delivery room meetings where we talk about the babies that are coming up for delivery. This just shows, since the STU opened, that if a baby goes on ECMO, they have a better chance of survival. Even if they're born through the tunnel, in the hospital that's connected to us, it's better to be right there and do the care from the very beginning. This has just showed some of the things we've learned from the videos, all the things that have to be done, right? All the tasks, especially on nursing. And the order of them is very variable. And so this has been a way to try to streamline that and to try to make it more standardized. We've also, because of those videos, changed where we have the CMAC. So used to, like, the resident fellow was looking over their shoulder. Now we're very careful about where it is. It's in the same place every time. The neonatal surgery team started in 2004, and this is a co-management team. This is neonatology with surgery, taking care of the babies together and rounding together. We actually do all of our surgeries down in the NICU. And that's just because we got them to the place we wanted to be. We don't want to move. And then our early management, is spearheaded with neonatology. This is Natalie Rentoul, who's been instrumental in writing guidelines that never existed in the world for how to take care of the babies from the first breaths. And then the pulmonary hypertension, right? It's such a variable thing, and it can be so unpredictable. We're pretty sure there's probably some inflammatory component to it as well. We're pretty sure that we can make it worse. We're pretty sure that there's a fixed component, but also a variable component. And so we need to always be working to try to make those variable components better. I put this in for Rachel Hopper, who's one of your cardiologists here, but we've changed the care so much that, like, when I was a resident or fellow, it was sort of a 50-50 endeavor whether or not we'd need ECMO, and it was sort of a 50-50 endeavor whether or not we'd live. Now it's more like 25% to 30% that we need ECMO, and if you get it, it's a 75% chance you're going to live. So it's really changed, and I think this is why. The cardiologists are our partners in this. They help direct us. We make decisions about timing of things like surgery, timing of, I don't know, even doing a fundo and a G because we don't want any soilage of the lung. So they really have helped us with this. That's mostly with an echocardiogram. We do laugh. I mean, you do sometimes say it's not the heart, like the past, but it's less and less often. And so, the echocardiograms, we're looking at the shunts and where they're located. We're also looking at ventricular function. We know that if ventricular dysfunction is lower, that they have a higher chance of death. And this is a CDH registry study done with Neil Patel. All right, so cardiology really matters. And so, there's the no-no trial now, like this whole controversy about nitric. What we were able to show is that if you actually know what the heart looks like, then using nitric sometimes can make a big difference. And so we still use nitric, but only if there's no LV dysfunction. And so this was work that was done by one of the fellows in the lab, Kendall Lawrence. We also know that a lot of times on those prenatal echoes, they call small left ventricle or stretched aorta. We never know what that means, right? So is there really a defect, or is it that you can't see it very well? How's it going to function? Is it apex forming or not? Is it small? We know the left-sided structures are smaller. And so recently, Maki Fraga and Kate Affable looked at this, and they showed that when you had smaller left-sided structures and LV dysfunction, it was definitely the highest odds of mortality. And so the reason that we have to go on ECMO is just because the level of support that we're providing isn't doing it. We're having to turn things up too high, or we're having spells. And so from the minute we go on ECMO, we're thinking, well, why do we go on, and how are we going to get off? And are we going to be able to come off before we do our CDH repair? And so it really depends on why we went on. So if it's for severe pulmonary hypertension and it's episodic, well, we might be able to come off. If they had evidence of good ventilation before we went on. So this is kind of like the George hybrid approach that he talks about from Michigan. If they have severe pulmonary hypoplasia, they never ventilated well, and pulmonary hypertension on top of it, there is no way we're going to get off ECMO without doing our CDH repair. And if we're going to do our CDH repair on ECMO, we should probably do it early. And then thirdly, the severe LV dysfunction and hypotension, this gets better. This gets better in a couple days. So this is the shortest run, actually. It sounds the worst, but it's the best. So this just shows the also CDH data is in the very first line, and you can see that the survival is worse than all the other reasons for neonatal ECMO. Still. What's happened with this cardiology partnership is that we have used high-level pulmonary hypertension meds earlier and earlier. And so Felix Debye recently did our summary of, this is Kendall's first 17 patients, but he recently, which show that the BNP improved, the echocardiographic parameters improved. So I can do this without the slide. So the treprostinil, it actually gets absorbed on ECMO, which we learned, which is good. And we're using it earlier and earlier. So we used to sort of be salvaged. It'd be like, you're still stuck on ECMO. We can't get off. Let's try a little Hail Mary. But now they'll be not even on ECMO yet. We'll see bowing into the septum. We'll have severe spells and we'll start it. And we'll sometimes avoid ECMO. All right, so that shows that. And echo is like one moment in time, it changes, it's dynamic. So anything we can do that can quantitate it is better. So this is work by Kate Affable looking at RV strain and correlating that with BNPs. It's most accurate after the repair's already happened. And then how are we for time? Okay, so this is just a cardiac phenotype, which is a great paper. It's in Seminars Perinatology. It's Neil Patel. And if you ever go to one of his talks, he will actually get 4 volunteers and he'll have them act out the chambers of the heart. It's quite entertaining. But this just shows like different sort of mechanisms and then how we should treat it. And so this is something that we adhere to. So we're surgeons. Finally, we get to talk about surgery. The issues with surgery for us are timing. When are we going to do the CDH repair? We're going to do it early. We're going to do it late. We're going to do it on ECMO. Where are we going to do it in the hospital? We almost always do it in the neonatal intensive care unit, unless we suspect something like hepatopulmonary effusion, or unless we suspect that, it looks like there might be a bowel atresia, or, sometimes there's weird things that come together. Of course, it's better to do a primary repair, but about 70% of the time we have to add something to the area. And so traditionally that was a Gore-Tex patch. Dr. Flake, who you guys met several years ago, said, I don't know why people are so upset about the patch. It's no big deal. We do it so well. So we did a little paper, drew our brackets just right, and it looked like our recurrence rates were low, our infection rates were low, like everything was great. But of course, it's all about where you draw your brackets, right? And so when we look longitudinally, we started having patients come in with issues. And so we have actually converted. I'll show you a little bit about how that process happened, and then complications. And so the synthetic patch repair is durable, but it's very challenging if you suspect infection. So every single time a baby in the NICU who has a patch, has a fever, you're like, how am I going to study this? How am I going to work it up? That's what it is? And it's really important because it can be potentially fatal if you miss it. And then the recurrence rates are high, around 11%, but in the literature up to 40%. And then the skeletal deformities, things like scoliosis, are actually higher as well. We then had a series of patients after Dr. Flake's report that came in with weird things. So this one has this little bump. The pediatrician called, there's a bump, like a little boil. I don't think it's got anything to do with anything. I want you to take a look. But then when you're looking at it, you're like, well, that's kind of where maybe the patch is sewn. And then another one had clubbing at age 4. This is an 11-year-old who had GI bleeding in this big inflammatory polyp. All of them had a patch infection. It's a CT scan showing the patch floating in some fluid on the right. And importantly, the presentations were very variable and they were diagnosed late. the quartile, the median was 383 days after repair, and the quartiles were 124 days and 1,428 days. So it's hard to predict, and you're not done. Just because they got through the first year or the first 5 doesn't mean you're out of the woods. And then in all cases, we took out the patch. We didn't always repair it. Like, we usually just took it out, let the dust settle, and about 40% of the time, that's about two-thirds of the time, 60% of the time, that's all we needed to do. They were scarred in. We actually never put anything in the place. And then the other patients, we usually put a biologic in. So we put in, a native tissue, so a lat flap, or in a couple of cases, we could actually do a transversalis flap. And so for this reason, we have converted to muscle flap repairs. This is popularized by Utah. They do them in the Dale Johnson era, and then they also reported doing them successfully on ECMO. The Toronto group has also reported on this. Ken Lichty's also reported this from Arizona. So it was actually, it's pretty old description, 1962. These are the pictures. So, we tell the parents there's, and then 71, they describe like a garage door coming down or a roll top desk. And so, the way we tell the parents is there's 3 layers to your abdomen. We're going to use the inside layer and flip it into the place. The nice thing is that even when it does recur, you can do a primary repair of that tissue. And so this just is a depiction from our artist. But of course, anytime you change something, then it feels like every patient had a small bowel obstruction from that raw surface area. It felt like every patient had a hiatal hernia from the pressure pulling it over the way it's sewn in. And so, you have 2 or 3 of those and you're like, what is going on? So we did look at it, and this is within the first year of life, and we saw no difference between either small bowel obstruction and hiatal hernia, even though it felt like every patient had it. And then finally, recurrence rates more approach a primary repair. And so in our patch cohort, it's 12% recurrence. In our primary repairs, it's 3%. And in our muscle flaps, it's 4%. So really, this is just the beginning, right? Like, it's not enough to count. It's not enough to just get discharged from the NICU. There's this long road ahead, and we're trying to optimize everything. So around the same time we had that co-management program start, we also started our long-term follow-up program. We initially called it the CDH follow-up program, but we realized there's patients with other congenital anomalies like large lung lesions that have to be resected emergently, or giant omphalocele where they have the really skinny dog chest, that act a lot like CDHs, or they need the same specialist, they need the same attention, they need the same level of attention. And so this is a rough sketch of our schedule. We see them frequently with nutrition and surgery, just, when they first leave, maybe every month. But then with the whole group that they met while they were in the hospital, cardiology, pulmonary, social worker, audiology, they see them. It's 6 months, a year, 2 years, 4.5 years, pre-K, and then as needed after that. And so that's with the full neurodevelopmental team, the neonatal follow-up team, and that's with all the other specialists. So we've enrolled, I think it's about 1,200 patients now, and you can see the orange bar, I think that's orange, peach bar are the CDH patients, and then the green are the lung lesions, and the blue are the omphalocele. So Marissa challenged me last night. She said, was she here today? Oh, oops. So she said, it's really, she goes, I feel really comfortable, and I know how to tell patients like how it's going to go in the NICU, how we're going to operate, how we're going to intubate, how we're going to do these things. But she said, I have a harder time telling them what life is like after that. And so this is for her. So the feeding challenges are the parents' number one. No parents want to have a little feeding tube, but 90% of our patients go home with a little yellow tube. And that's because, if their neurodevelopmental outcomes and their lung growth outcomes are linked to their nutritional outcomes. And so it's very important. So this just shows a smattering of how and it's been pretty consistent. So the green, which is the largest group, is a combination of NG and GPO. The peach is all PO, and then the blue is G2. So we only operate on 15 to 20% of them for fundo Gs. And then the purple is a post-pyloric tube. Now, some of these had a FundOG that didn't really work, because if your liver is still huge and you still have pulmonary hypertension and your liver is sitting on your gastric outlet, it doesn't matter if you get a FundOG, right? So some of those patients we're aborting the GJ and we're aborting the FundOG and going right to a GJ. And then finally, what does life look like? CDH neurodevelopmental outcomes. Every team needs an Enrico. He's just taken on this challenge. He has characterized our population, infancy, preschool, pre-K. He showed that total maturation score bar MRI, which is a MRI brain measurement, is lower in CDH, similar to the congenital heart patients. He's shown perinatal factors that influence neurodevelopmental outcome. He's shown that every single week, even at the near term, even 38 versus 39, it matters for your neurodevelopmental outcome. He's shown that ECMO and repair on ECMO have lower neurodevelopmental scores. And so this idea of trying to be off ECMO when we do the repair is there's a real reason. He showed no increased risk, depending on how fancy your MRI machine is. He also showed that seizures happen in about 20% of our patients and they're undetected, right? They're just by EEG, but all of those patients had more adverse outcomes. And then a 9-fold higher rate of autism in the CDH population, 14% versus the population is like 1.5%. And then executive function and attention challenges, which look very much phenotypically like the congenital heart patients. So this just shows the normative curve, the bell curve, and you can see that our CDH patients in the bottom, the more colorful one, there's more that are on this tail. And that tail, those patients have congenital anomalies and they have had persistent pulmonary hypertension and hypoxic events in the hospital. We also looked at our 8 to 13 school age group, and this is a satisfying story in that they look, and this is comparing the lung lesions, angina omphalocele, and the congenital diaphragmatic hernia. They have, on average, good scores. So if you can get through it all, if you can get through the gauntlet, it looks like it's a good thing. And so the details of every phase have lasting consequences. The long-term follow-up is critical to having us change what we do in the real time while we're taking care of our patients. And then collaboration is key. This is an old picture, and I had convinced myself that the tall guy on the right was Carl, but he tells me it's not him. So this is just a build it and they will come. This is the very first fetal reunion back in 1996 or 7. And then this is last year. So they have to rent out the zoo, and it's thousands of people. There's always work to do and lots of work to go forward, and we're going to keep pushing the envelope. So I really appreciate your invitation to be here.